My name is Vinny Melnick from the Mallinckrodt Institute of Radiology Abdominal Imaging section, and my topic for today is the abdominal wall and peritoneum. I have no relevant financial disclosures. As a broad overview, both the abdominal wall and peritoneum are large potential spaces for both focal and diffuse processes, including neoplastic, traumatic, iatrogenic, inflammatory, and infectious processes. In this 20-minute or so case-based review, I'd like to review some common and uncommon pathologies that you may encounter in both of these compartments. This first case is a pretty common clinical scenario in most practices. This is a patient presenting with a palpable abdominal wall mass. An ultrasound was performed that demonstrates an oval mass similar in echogenicity to the surrounding subcutaneous fat. It parallels the skin and has very little internal vascularity on color Doppler. A CT performed several years later for a different reason redemonstrated what is clearly an abdominal wall lipoma. These are a very common abdominal wall mass. They're often painless, but patients can present due to a palpable abnormality. They're composed of mature adipose tissue. On ultrasound, as in this previous case, they present as a mass that parallels the skin, similar echogenicity to the subcutaneous fat, and with little vascularity and no posterior acoustic enhancement. On CT or MRI, typically these masses appear simple with the same attenuation and signal as the surrounding fat. Now contrast this case with this one of a large fat-containing mass, in this case arising in the retroperitoneum, with multiple solid-appearing nodules and extensive stranding. This certainly would be concerning for a liposarcoma and can occur in the abdominal wall as well. Other liposarcomas, such as leiomyosarcoma, can also occur in the abdominal wall, but these are relatively uncommon. At a glance, this looks very similar to that liposarcoma case in that there is an abdominal wall mass containing elements of both fat attenuation and soft tissue attenuation in the left mid-abdomen. However, in speaking with the patient, this was a site of repeated insulin injection in a diabetic patient, and this is a case of insulin-related abdominal wall lipohypertrophy. So something to keep in mind in the differential diagnosis for a fat-containing abdominal wall mass. In contrast, here's a patient with a palpable mass in the left upper quadrant. You can see that this mass appears relatively solid. It has spiculated borders and is accompanied by a similar appearing mass in the mesentery, which again looks spiculated. There's thickening of the gastric outlet, and there is a missing colon. And so this is a patient with Gardner Syndrome and multiple abdominal desmoids. Gardner Syndrome is a manifestation of familial adenomatous polyposis, which is autosomal dominant, typically with patients presenting early in life. They have multiple colonic polyps with a near 100% risk of colon cancer. They also have other GI tract adenomas and adenocarcinomas, including around the ampulla of the duodenum. They also get skull and mandible osteomas, mesenchymal skin tumors, and as demonstrated in that last case, desmoid tumors. Here's another patient with a solid appearing abdominal wall mass, in this case near the umbilicus. This patient had a painful mass and has a history of prior laparoscopy at this site. On MRI, it appears heterogeneous on both T1 and T2 weighted images and is relatively T2 dark. At surgical excision, this was found to be a focus of endometriosis in a patient with prior diagnostic laparoscopy. Abdominal wall endometriosis is relatively uncommon but results from ectopic endometrial tissue implanting, typically along a surgical scar. Clinically, this presents with pain at the scar, which may or may not be cyclic. Classically, this happens following a C-section. And on imaging, there's a nonspecific nodular mass that may be spiculated and may or may not enhance. Here's another example of an endometriosis involving the abdominal wall, in this case at a C-section site. Here's another patient with abdominal wall findings that are key to their diagnosis. Notice multiple soft tissue nodules within the skin, both anteriorly and posteriorly. In this patient, who also has several small nodules arising from the submucosa of the proximal small bowel. This was a patient with neurofibromatosis presenting with multiple neurofibromas as well as gastrointestinal stromal tumors arising from the small bowel. So to briefly recap the differential diagnosis for solid abdominal wall masses, they include not only lipomas and sarcomas, as we mentioned, but also metastases, classically from melanoma or breast cancer, abdominal desmoid tumors, especially in patients who have Gardner Syndrome, endometriosis, often along prior surgical scars, and neurofibromas as well. Here's a patient with an acutely painful palpable abdominal wall mass. These are pre- and post-contrast CT images demonstrating a hematocrit level within the mass and marked surrounding soft tissue stranding. After administration of intravenous contrast, there are 2 foci of active extravasation, and this is an abdominal wall hematoma that occurred in the setting of anticoagulation and a spontaneous bleed. Abdominal wall hematomas may be post-traumatic or spontaneous, such as in that last case. The most common location for them is within the rectus sheath. They have a variable appearance on ultrasound, of which there are 2 representative images here. Notice that it can be mostly cystic with septations or even solid appearing on grayscale imaging. On CT, hematomas are classically hyperattenuating, but the appearance does vary with acuity, and on MRI they are classically T1 hyperintense. Here's another patient with a palpable abdominal wall mass, in this case a long-standing mass. On ultrasound, there was an oval mass with echogenic foci and posterior acoustic shadowing. The differential diagnosis includes a calcified mass as well as a gas-containing mass, and we weren't able to discern much more than that on this initial exam. The CT clarified things in that there is focal herniation of the cecum at the lateral aspect of the rectus sheath, with intraluminal gas and stool causing that echogenic focus on ultrasound. So this was an abdominal wall hernia masquerading as a mass on ultrasound. Abdominal wall hernias have many different subtypes. Discussing all of them is beyond the scope of this talk, but certainly broadly includes ventral, umbilical, and lumbar hernias. Again, they may mimic a mass, not only clinically, but potentially on ultrasound, and so the use of Cine images and Valsalva may be helpful, but ultimately CT or MRI may be needed to further characterize them. Well, here's another case of an abdominal wall hernia, in this case posteriorly. This is also different in the sense that this was an acute presentation. This patient was in a motor vehicle collision. So notice that the patient has a right-sided traumatic inferior lumbar triangle hernia. There's also mixed attenuation material within the small bowel mesentery and surrounding multiple bowel loops, as well as within the pelvis, with perhaps a focus of active extravasation in the small bowel mesentery. So this is a traumatic lumbar hernia associated with bowel injury and hemoperitoneum. Traumatic lumbar hernias are rare. They result from high-impact blunt trauma, resulting in a blowout injury to the abdominal wall. These are important to observe because they have a very high association with bowel and mesenteric injuries, and these patients are at risk for delayed complications due to the hernia itself. Here's another trauma patient with abdominal wall findings. In this case, there is a high-grade injury to the infrarenal abdominal aorta with a surrounding retroperitoneal hematoma. There's at least an anterior column spine fracture, and then in retrospect, this diagnosis wasn't made prospectively, but there's infiltration of the fat posterior to the lumbar spine, which is a common place to observe degloving injuries, which was later diagnosed in this patient. These are also known as Morel-Lavallee lesions, and they occur due to a shearing or closed degloving type soft tissue injury. They're commonly seen around the hips and pelvis, but can be seen over the lumbar spine as well. These injuries result in disrupted subcutaneous veins and lymphatics with hematomas and recurrent fluid collections. This is another example of a patient with a Morel-Lavallee lesion involving the body wall, in this case overlying the gluteal soft tissues. and she presented with recurrent fluid collections. Another trauma case, another case with clues in the anterior abdominal wall. Notice that there is a fracture of the left pubic symphysis and that there is expansion of the left rectus muscle compared to the right. Also, there's high attenuation at the pubic symphysis. So somebody certainly were worried about pelvic trauma here, potentially with active bleeding. Clinically, they were presenting with hematuria, and so a CT cystogram was performed that demonstrates extraluminal contrast. Notice that the contrast is in that expanded rectus muscle and rectus sheath with sort of a septated or webbed type appearance of that anterior contrast. But also notice that there's contrast surrounding multiple small bowel loops. And so this patient has both an intraperitoneal and an extraperitoneal bladder injury, as evidenced by these findings. It's important to separate extraperitoneal and intraperitoneal bladder injuries. Extraperitoneal bladder injuries often present with abdominal wall findings, typically with contrast from the bladder collecting in the rectus sheath or space of Retzius, and these injuries are typically managed conservatively with a Foley catheter. Intraperitoneal bladder injuries result in contrast surrounding bowel loops or within the rectovesicular space or pouch of Douglas, and usually these are repaired because of the potential to cause electrolyte abnormalities. But keep in mind, such as in this case, a certain percentage of them, approximately 15%, may be seen in combination. Well, here's a person with peritoneal inflammation, certainly less dramatic than that last case of a bladder injury with extraluminal contrast. In this case, there's an oval fat density lesion along the sigmoid colon with surrounding inflammation. There are no associated diverticula, and there's really only one thing this can be. This is Epiploic Appendagitis, causing this patient's presentation to the ER with left lower quadrant abdominal pain. Epiploic Appendagitis manifests exactly in this way, that is, a fat density oval lesion with surrounding inflammation. Often they're associated with the descending or sigmoid colon. They can have an associated central dot, which is a small thrombosed mesenteric vein, approximately 50% of the time. It's important to make this diagnosis and not something else because the treatment is typically pain management. The differential diagnosis can include an omental infarct. Those are more commonly right-sided, as I'll demonstrate here. On the top, there are two examples of epiploic appendagitis involving the descending and hepatic flexure of the colon, both of which have the classic central dot type appearance. Contrast that with the omental infarct abutting the liver, as well as this lesser sac omental infarct. In reality, although this is an important anatomic separation, the treatment for these entities is the same, but it's important to keep them both in mind when you see inflamed fat within the abdomen and pelvis. Here's another person for whom fat is a little bit of a clue as to what the underlying diagnosis is. There's a very nodular process involving multiple compartments, including the transverse mesocolon, the retroperitoneum, surrounding the ascending colon. But notice, as I alluded to, there are small locules of fat within this process. And this patient had an unreported episode of pancreatitis about a month prior to this CT. And so this was peripancreatic and retroperitoneal fat necrosis presenting from prior pancreatitis. And so remember that patients who have pancreatitis may not necessarily present acutely, and that peripancreatic necrosis can be confusing. It can involve multiple compartments, and observing the inflammatory stranding as well as the internal fat globules from the autodigestion of the fat can be a helpful observation. Here's a person with multiple collections of fluid throughout the abdomen and pelvis. Notice that these collections of fluid are scalloping the surface of the liver, they're indenting upon the surface of the stomach, and there are loculated collections within the pelvis. This is a fairly classic appearance of Pseudomyxoma peritonei. That disease presents with gelatinous ascites, most commonly caused by a ruptured mucinous tumor of the appendix. That happens about 90% of the time. The rest of the time, other tumors can be implicated, including GI and GYN sources. The CT findings classically are that scalloped appearance to the liver and spleen with fluid attenuation, collections of loculated ascites, and there can be associated calcifications. Contrast that last case with this somewhat similar case of multiple fluid attenuation and or intensity collections along the surface of the liver and the spleen surrounding the stomach. Notice, though, that this person has had prior liver resections, and also notice that there are multiple additionally septated smaller cysts within these collections. And so this patient has a history of prior echinococcal resection from the liver, and this is peritoneal seeding of echinococcus or hydatid disease involving the peritoneal cavity. Here's another patient with several low attenuation rounded collections throughout the peritoneal cavity, including the left adnexa, the small bowel mesentery, and along the liver surface. Notice, though, that this is higher attenuation than simple fluid. This looks a little bit like blood attenuation. This is a reproductive age woman with cyclical abdominal pain, and this is another case of endometriosis, in this case occurring diffusely throughout the abdomen and pelvis. Here's a person with a moderate to large volume of ascites. In this case, not loculated ascites. It looks pretty diffuse. Also notice that there is thickening of the peritoneum diffusely. The omentum is hard to make out because it's infiltrated with inflammation. But notice that there's no definite soft tissue mass within the peritoneum or omentum. This is not a patient with a known primary malignancy. However, she was having night sweats and weight loss. And so after paracentesis and omental biopsy, a diagnosis of peritoneal tuberculosis was made. Remember that peritonitis is the most common abdominal presentation of tuberculosis. You may have peritoneal tuberculosis without lung findings. You should think about it when you see diffusely smooth peritoneal thickening and infiltrated looking omentum, especially in appropriate patient populations such as patients who have had a travel history or in immunosuppressed patients, particularly those on TNF alpha blockers such as in Crohn's disease. Contrast that with this case of another patient with a decent amount of ascites, peritoneal thickening, but in this case, much more nodular appearing and a much more infiltrated, caked appearing omentum. This is a patient who ultimately was given a diagnosis of peritoneal mesothelioma. But when you're looking at diffuse peritoneal malignancy, it's important to remember a few potential diagnoses. The most common presentation we see is metastatic carcinomatosis from either a gynecologic or a gastrointestinal source. Mesothelioma certainly can cause this, as can peritoneal lymphoma, as in this case here on the right. And really, the key differentiator between an infectious peritonitis and that of peritoneal carcinomatosis is the nodularity. Certainly someone with a known malignancy would be a telltale indicator that you're dealing with cancer, but ultimately soft tissue sampling may be warranted. Well, here's another person with not simple appearing ascites. There are loculated collections of fluid on both sides of the abdomen. Also notice that some of this soft tissue in the omentum abutting this collection is calcified, and that the patient has a transplant kidney. They're also presenting with a small bowel obstruction. Notice that the bowel loops are centrally located within the abdomen at a transition point of this obstruction here. This is a person who's had prior peritoneal dialysis, and this is a case of sclerosing encapsulating peritonitis, or so-called cocoon abdomen. It's a rare complication of peritoneal dialysis. On imaging, they present with peritoneal and serosal thickening. Later in the disease, such as in this case, they can get diffuse calcifications of the peritoneum and the serosa as well. They often present with loculated fluid collections and recurrent bowel obstructions as well. Here's another patient with peritoneal calcification as the clue to their diagnosis. They're recently post-operative. Notice that on this initial study, there is some mild infiltration of the mesenteric and peritoneal fat. but no calcification. However, 2 weeks later, we can see faint calcifications developing in the subxiphoid peritoneal fat and omentum, as well as within the leaves of the mesentery. And this was development of peritoneal and mesenteric heterotopic ossification. It's important to remember this diagnosis because it can occur very quickly, and in patients who are undergoing evaluation for an anastomotic leak, it's important to not confuse this for oral contrast. And so it may be helpful to evaluate these patients with pre- and post-contrast imaging when this diagnosis is suspected. Lastly, here's a case of someone with a high-density focus in a peritoneal collection here. That's the key to their diagnosis. Notice this collection is heterogeneous. There are fluid attenuation foci as well as septations. But again, this high-density area is the key to diagnosis. On this MIP image of the abdomen, notice that it has a serpiginous appearance, and this is diagnostic of a retained sponge or Gossypiboma. Most Gossypibomas are found in the abdomen, perhaps because that's the largest potential space for them to be lost. It may mimic a mass or an abscess, and in the acute setting may have mottled internal gas, but really observing this high-density sponge marker is diagnostic for this process, and important for radiologists to make that observation. So to recap, we talked about abdominal wall masses, not only to look at signal intensity and attenuation, but also to correlate patient history. Is it a patient who's had prior surgery in which we might think about a desmoid tumor or perhaps an endometrioma? Is it a patient with neurofibromatosis? Helpful clues that might allow us to be more specific in our differential. Hematomas are very common, but also remember other post-traumatic findings, including acute lumbar hernias, extraperitoneal bladder ruptures, and Morel-Lavallee lesions. We talked about causes of focal and diffuse peritoneal inflammation, including tuberculosis. And we also talked about causes of disseminated peritoneal malignancy, including peritoneal carcinomatosis, but also mesothelioma, Pseudomyxoma peritonei, and lymphoma. Thank you very much for your attention.